Hey, welcome to Micro Lesson. Today we are talking intermittent compression. I am really excited that you're here with us. We're going to be talking about primarily the two principles that are driven from intermittent compression. We're going to show you some tools and then actually turn them on and show you how we use them here. But number one, we have to understand that principle of intermittent compression. Why is that used? It's actually called intermittent pneumatic compression, so there's air with that. But we use that, and you can see right here on the whiteboard behind me, to spread and push fluid. And so when we put that device on our patient, what we're doing, therapists, is we're literally taking a mechanical device surrounding that circumferentially around a joint, and we are pushing fluid. And that fluid, what we really like to call it, because we want to sound smart, we want to call it edema. Fluid doesn't make us sound real smart, but edema does. And edema is a really critical component to get out so that healing can occur. In fact, your textbook that you would have used in our program would say this, that there are three primary goals of using intermittent pneumatic compression. Number one is edema, but there's a downstream effect to that. If you take out the edema, then immediately you're going to up range of motion and you're going to decrease pain. And all of us know that those two things are the primary factors in getting our patients back better. Now, before we look at those devices, let me just kind of come over here and talk about this little trickster right here, the DVT. We all know that the deep vein thrombosis, big safety, big red flag item for us in therapy. We don't want our patients to have those. So what are we going to do? Well, we're going to pay attention to the fact that intermittent compression is a great prevention tool for DVT, but it is not a great treatment tool once a DVT has been diagnosed. No. We don't want to put that intermittent compression on that patient who has a DVT actively, because what's that going to do? That's going to dislodge that DVT. That dude's going to travel right up from their calf area. It's going to go right into their lungs as a pulmonary embolism, and they're going to die. And we don't want that to happen. We want to use this, though, as a technique to prevent that DVT. Now, where are you going to see that? You're going to see that in hospital settings. You're going to see that possibly in the acute hospitalization, or maybe even as a post-surgical thing. And if you do, they're probably going to be bilateral, and that's going to be a little cuff around the foot and the ankle, and it's going to be on there pretty much the time that they're in bed. And it's a great tool to use, because if it's applied pretty much at the time of hospitalization or post-surgically, then what it does is it helps to mechanically move fluid from a high pressure area, which it becomes a high pressure area once we introduce the compression, to a lower pressure area. And so if we're pushing fluid upwards, what we're doing is we're removing it, and that gives space for that good, healthy blood with all that good nutrition to come in there and circulate and do what it's supposed to do anyways. So let's talk about our tool for just a minute. And I've got a great model who's helping me today, and I'm really excited to introduce my model, because this model, in the day of COVID-19, has no droplets that he can spread on me. And his name is Bony Tony, and we use him for a lot of things in our program here. But Bony Tony is wearing both of our devices. And so I'm going to show those to you right now. And what you're going to see is, first of all, the upper extremity device. Now, our textbook teaches that you're going to use an upper extremity device, and I actually have the shoulder one on here for possibly use of a shoulder type injury. But there's also other extensions to this, other specific cuffs that we can use that would go distal to that and possibly be used for lymphedema. And we're going to talk about that here in a minute. But we also have one going on the lower extremity, and this is a monster of a cuff. Look at that. That goes from Tony's toes to Tony's ischial tuberosity, man. So we are talking about some major lower extremity compression going on here. Now, some things to know. If we're looking at an upper extremity issue, we're only going to make our settings at a 40 to 60 millimeters of mercury pressure gradient. And then if we're looking at our lower extremity, well, we can kick that dude up 60 to 80. and have no real big concerns. Now, of our machines here, we have this nice little intermittent compression unit that's pretty common and used a lot in therapy. And it's hooked to our lower extremity unit, and it pumps up, and it should have an automatic 3-to-1 duty cycle. But then we come over here, and I've got my BCI portable cold compression therapy system. This is a rock star among therapy systems for compression, because this little guy right here, I can put ice and water in this little machine right here, and I can introduce cold with my compression. Now, we talked about how there was an acute hospitalization setting for compression, but this little guy right here is like the bomb.com when it comes to compressing an acute injury. Acute injury, acute hospitalization, two different things. That acute injury, like a sprained ankle, or maybe you just hurt your shoulder like Tony did here, or maybe you hurt your knee or your ankle, this thing right here, money, because it's going to bring in compression on top of that ice. And if you remember from class, rest, ice, compression, elevation, those are your top 4 things to do when you have an acute injury. So this machine right here does 2 of those for me, and then I can come in with a nice little elevation tool like that bolster you see over in the corner, and I can lift up a lower extremity, or I can just prop them up and really get that great holistic rice component going. Now, on our machine here, what I want you to notice is that there's some things going on here. Number one is an on and off. It also has an inflate and deflate. And you always want to select that inflate deflate, because after all, you're doing an intermittent compression, not a continuous compression, right? And so that's a critical thing. That means that it goes on and it goes off, and that's going to speak to our duty cycle. And we'll talk about that here in just a moment. It actually gives me options on running it every 30 seconds, and then every 30 seconds off, running for 10 seconds. That's the 3-to-1 magic ratio that we're going to talk about here in just a minute. But it also gives me this really critical selection right over here of how much compression do I want. And I know that's kind of hard to see there. Maybe you can see it on this side. 15 millimeters of mercury at the bottom, 50 millimeters of mercury in the middle, and then 75 millimeters of mercury at the top. So here's where it becomes pretty critical, therapists, is you got to be able to select and know what you're doing for what treatment. Again, 60 is about like the top number for your upper extremity, 80 about the top. I know that one goes to 90 for our lower extremities, and we want to kind of keep in that range. And your textbook is got a great guide on that. But some other things that we need to kind of consider about this treatment, if we're going to use it, is this right here. Are we going to be using cold? If we are, then we need to alert our patient and tell them, hey, listen, this thing's about to get cold. And anytime you introduce compression with cold, you're like magnifying that cold. It's going to get seriously cold then. I mean, it's like totally different than laying a cold pack on and just kind of like, ooh, there it is, it's chilly. But when you bring in that compression, that dude's squeezing, so it's going to get really cold. If you do that, our machine, it auto selects it, and because it has a very specific volume level for that ice and water to go in right there, and this is one of our tubes right here that it goes in, it's only going to allow a 50 to a 55 degree max. So that's already done for us. But that's optimal for bringing cold into compression. Number 2, we need to be looking at diastolic blood pressure. One of the tools that I have set out right here next to my compression is one of these guys right here. That's right, the old blood pressure cuff, otherwise known as a sphygmomanometer and a stethoscope. Those are great words that we like to toss around, but that's a really critical thing to do. And you need to know diastolic pressure. That's right, the bottom number. This is where it becomes critical. And you need to know that because that number tells us when the arterial and venous systems are relaxed, and we're never going to take that pressure gradient above that. So it always has to stay below. That 3-to-1 duty cycle that we saw where it runs, or it's quiet for 30 seconds, runs for 10. There it is right there, duty cycle. That means how often it's working. We've seen that in ultrasound, also with E-stim. Very important that we remember the duty cycle. Also, duration, 20 to 30 minutes is max. Now, if you're looking at a lymphedema patient, That's going to go up a little bit because they can wear theirs a lot throughout the day. That's another story we'll talk about another time. And then the last thing here is always patient education. Tell the patient, listen, this is going to get cold, or maybe, hey, listen, this is going to squeeze. Why do they need to know that? Because patients don't know that. Patients always deserve your top priority to be educating them on what they're going to experience. That being said, I hope you enjoyed the video. Take a look at our questions below. See which ones you can answer. Make sure you comment. See you soon.